Welcome to this e-course on adolescent HIV care and treatment. This module contains audio. Please adjust your speaker settings as necessary. You may activate the audio presentation by clicking on the audio icon, located in the bottom left or bottom right corner on each slide. To advance from one slide to the next, click the right arrow if in slideshow mode. Alternatively, you may be able to use the page down function or simply to click open the desired slide. Click on the right arrow for a description of the e-course and to begin the module. This module is intended for providers of care for adolescents living with HIV in resource-limited settings, including clinicians, clinical officers, nurses, midwives, and pharmacists. It aims to enhance participants' ability to provide evidence-based, appropriate, quality, and accessible care to adolescents living with HIV. The module summarizes recommendations made by the World Health Organization on the care and treatment of adolescents living with HIV. After completing this module, you will be able to 1. Understand modes of HIV transmission in adolescents. 2. Describe what is meant by adolescent-friendly health services. 3. Understand when and how to initiate and monitor antiretroviral therapy in adolescents. 4. Understand the principles of transition from pediatric to adolescent care. 5. Describe the specific needs of adolescents from key populations. And 6. Understand WHO recommendations for the prevention of cervical cancer in adolescent girls. Adolescence is marked by rapid developmental, emotional, and social changes. What are some of the recognized challenges of adolescent HIV care? They have a high risk of loss to follow-up and commonly exhibit suboptimal adherence to HIV treatment, making them vulnerable to poor treatment outcomes. Adolescents have special requirements for comprehensive care, including psychosocial support and the wider range of sexual and reproductive health services. Yet they may face significant barriers to accessing and remaining in treatment, care, and support services, often due to policy and legal barriers related to the age of consent. Adolescents can acquire HIV infection in two ways. The first is by vertical transmission, where HIV is acquired perinatally through transmission from an HIV-positive mother. Adolescents living with HIV include long-term survivors of vertical transmission. The second is through horizontal transmission. This can occur in two ways: sexual transmission from an HIV-positive sexual partner, and non-sexual transmission, such as injecting drug use, through traditional and other practices requiring cutting of the skin, such as female genital mutilation or scarification with shared razor blades, and through medical procedures, such as unsafe surgical procedures, injections, and blood transfusions. Adolescents can acquire HIV infection in two ways. The first is by vertical transmission, where HIV is acquired perinatally through transmission from an HIV-positive mother. Adolescents living with HIV include long-term survivors of vertical transmission. The second is through horizontal transmission. This can occur in two ways: sexual transmission from an HIV-positive sexual partner and non-sexual transmission, such as injecting drug use through traditional and other practices requiring cutting of the skin, such as female genital mutilation or scarification with shared razor blades, and through medical procedures such as unsafe surgical procedures, injections, and blood transfusions. This slide provides a visualization of the distribution in perinatal versus sexual modes of transmission in African adolescents. Among 15 to 19-year-olds in sub-Saharan Africa, 1/3 of girls with HIV and 2/3 of boys with HIV are estimated to have acquired their HIV infection perinatally. Let's get started by summarizing the key information from WHO on definitions, diagnosis, and disclosure as they relate to adolescents. WHO defines an adolescent as a person aged 10 to 19 years inclusive. In some settings, however, individuals 15 to 19 years of age are considered adults. HIV testing services with linkages to prevention, treatment, and care should be available to adolescents in all settings. WHO recommends that adolescents with HIV should be counseled about the potential benefits and risks of disclosure, and they should be empowered and supported to determine if, when, how, and to whom they disclose their HIV status. WHO further defines the availability of HIV testing services with linkage to prevention, treatment, and care based on the type of HIV epidemic. In generalized HIV epidemics, these services should be offered to all adolescents. And in concentrated HIV epidemics, these services should be accessible to all adolescents. Let's now move to the principles of adolescent-friendly health services and how they are applied to HIV services. As mentioned in the introduction to this module, adolescents face significant barriers to accessing and remaining in HIV treatment and care services. The implementation of adolescent-friendly health services is proven to improve health outcomes and utilization and acceptability of services for adolescents, including those living with HIV. WHO recommends that these services be developed wherever possible, with a specific focus on support for adherence and retention in care. Adolescent-friendly health services have the following characteristics as defined by WHO. They should be equitable and accessible, with all adolescents, not just certain groups, being able to obtain the health services they need. They should be acceptable and appropriate, with health services provided in ways that meet the expectations and the needs of adolescent clients. And finally, they should be effective, with the right services provided in the right way so as to make a positive contribution to the health of adolescents. The WHO Quality of Care Framework recommends the following considerations for adolescent HIV programs. Establish linkages and referral pathways to ensure a comprehensive continuum of care, including for the transition from pediatric to adult HIV services. Ensure healthcare worker training and personal development opportunities in adolescent HIV treatment and care. Engage service providers, adolescents, and key stakeholders to identify acceptable and feasible services and activities. Implement adolescent-friendly health service approaches in all HIV services used by adolescents. Address the needs and vulnerabilities of adolescents from key populations. This next section covers recommendations on antiretroviral therapy for adolescents. WHO recommendations for the initiation and monitoring of antiretroviral therapy in adolescents are exactly the same as those for adults. Since 2016, WHO has recommended that ART should be initiated in all adolescents living with HIV, including pregnant and breastfeeding women, irrespective of WHO clinical stage or CD4 count. Further, WHO recommends as a priority that ART should be initiated in all those with severe or advanced HIV clinical disease, which is WHO clinical stage 3 or 4, and all those with a CD4 count less than or equal to 350, if known. Aligning with the initiation criteria for adults simplifies programming and expands ART coverage, creating opportunities to engage adolescents living with HIV in care. What ART to start in adults and adolescents? In July 2019, WHO updated its recommendations for first- and second-line antiretroviral regimens. The new recommendations are based on evolving evidence on safety and efficacy, and on programmatic experience with the use of dolutegravir in women of childbearing potential, and the use of efavirenz 400 mg in pregnant women and in people co-infected with tuberculosis. Dolutegravir in combination with an NRTI backbone is recommended as the preferred first-line regimen for adults and adolescents living with HIV, initiating ART. Efavirenz at low dose, 400 mg, in combination with an NRTI backbone, is recommended as the alternative first-line regimen for adults and adolescents living with HIV, initiating ART. Special situations in which other drugs may be considered include the non-availability of preferred and alternative first-line drugs, and the use of a boosted protease inhibitor instead of efavirenz, if the national prevalence of pretreatment resistance to efavirenz or nevirapine is 10% or higher and no other alternatives are available. TAF, or tenofovir alafenamide, may be considered as an alternative to TDF for people with established osteoporosis and/or impaired kidney function. Exposure to dolutegravir at the time of conception has been associated with an increased risk of infants being born with neural tube defects. Effective contraception should be offered to adult women and adolescent girls of childbearing age or potential receiving dolutegravir. Dolutegravir can be prescribed for adult women and adolescent girls of childbearing age or potential who wish to become pregnant or who are not otherwise using or accessing consistent and effective contraception, if they have been fully informed of the potential increase in the risk of neural tube defects at conception and until the end of the first trimester. If women identify pregnancy after the first trimester, dolutegravir should be initiated or continued for the duration of the pregnancy. Regimens containing efavirenz 400 mg and efavirenz 600 mg are comparable for viral suppression. Efavirenz 400 is better tolerated than efavirenz 600 with a lower risk of treatment discontinuation. Efavirenz 400 is expected to be as safe for pregnant women to use as efavirenz 600. Pharmacokinetic and pharmacodynamic studies suggest that drug concentrations decline slightly with efavirenz 400 mg but remain within the therapeutic range and are unlikely to result in reduced efficacy. Efavirenz 400 can be co-administered with rifampicin-containing TB treatment regimens, is well tolerated, and plasma concentrations are maintained above the levels considered to be effective. Please note that it is not advised to use efavirenz 400 and efavirenz 600 in settings with high levels of pre-treatment HIV drug resistance. WHO recommendations on sequencing options for first and second antiretroviral regimens for adults and adolescents are summarized in this table. For adults and adolescents who initiated therapy with tenofovir plus 3-TC or FTC plus dolutegravir, the second regimen should be AZT plus 3-TC plus a ritonavir-boosted protease inhibitor, either atazanavir or lopinavir. For adults and adolescents who initiated therapy with tenofovir plus 3-TC or FTC plus efavirenz, the second-line regimen should be AZT plus 3-TC plus dolutegravir. Alternative second-line regimens are listed in the last column. Studies have shown that people who initiate antiretroviral therapy on the same day they are diagnosed are more likely to be linked to care, remain engaged in care, and be virally suppressed. Numerous cities around the world have moved to provide same-day treatment initiation, including Melbourne, New York, and San Francisco. WHO recommends that rapid ART initiation should be offered to all people living with HIV, including adolescents, following a confirmed HIV diagnosis and clinical assessment. Rapid initiation is defined as within 7 days from the day of HIV diagnosis, taking note that people with advanced HIV disease should be given priority for assessment and initiation. Same-day treatment initiation must in all cases be voluntary. Retention in ART programs is a major challenge in all settings and across populations, specifically among younger, adolescent populations. Multiple factors may play a role in loss to follow-up, including distance to health facilities, lack of transport or inability to cover travel expenses, issues related to stigma and disclosure, and a lack of understanding about the necessity of lifelong care. WHO recommends that the mainstays of interventions to maximize retention in care are community-based support services, adherence clubs, patient advocates, and differentiated service delivery. Peer-based support services are especially impactful for adolescents. In this slide and the next, we see 2 examples. This slide depicts the impact of the Operation 000 Adolescent Peer Mobilization Program in Kenya. This program engages adolescents and young people living with HIV into OTZ clubs, where they are offered comprehensive HIV treatment literacy education and empowered to be self-health managers. Further, the adolescents commit to the simple treatment goal of achieving 3 zeros: 0 missed appointments, 0 missed drugs and medications, and 0 viral load. Self-reported adherence across the programs has increased from 88% in October 2017 to 96% in February 2018, and viral suppression rates showed significant improvement within 6 months of membership, as illustrated in this slide. The Zvandiri program in Zimbabwe is the second example. This program promotes peer counseling in differentiated care of adolescents and young people living with HIV between the ages of 6 and 24 years. Community Adolescent Treatment Supporters, CATS, are HIV-positive young people aged 18 to 24 years who are engaged to work between health facilities and the homes of youth living with HIV to promote an increased uptake of testing, linkage, adherence to treatment, retention in care, and services related to sexual, reproductive, and mental health. Community Adolescent Treatment Supporters work with health facilities supervised by the Ministry of Health and work closely with social workers, community health workers, and clinic health workers supporting young people living with HIV through the comprehensive range of services. At the same time, they act as positive role models and in this way strengthen existing networks of social protection. With more HIV-infected children and adolescents surviving into adulthood, the transition of these young patients into adult care is evolving as a priority for health services. For adolescents living with HIV, transition is the purposeful, planned movement from pediatric, child-centered, or specialized adolescent services to adult-oriented services. The main goal of transition is for adolescents to develop the ability and confidence to be autonomous and responsible for their HIV care by the time they are engaged with adult services. Transition may also occur within comprehensive family services, from one provider to another, or with the same provider adopting different approaches that recognize the adolescent's evolving capacities and needs. A good transition process supports adolescents to acquire knowledge and build life skills, to reduce the risk-taking behaviors that can interfere with adherence to treatment and retention in care. Transition needs to be carefully planned and managed, taking into consideration the adolescent's medical, psychological, and social needs. Carefully planned transition recognizes the evolving developmental, medical, emotional, educational, and social needs, which may vary according to the timing and mode of infection of the adolescent living with HIV. Transition can be challenging. Adolescents may be anxious about leaving the safety of pediatric services and the comfort of dependence on caregivers, as well as having to engage with unfamiliar HIV clinics or providers. Parents and caregivers may be unsure about their child's capacity for autonomy and ability to understand their illness, or they may be fearful of disclosure to others. This hesitancy on the part of parents, caregivers, and even healthcare providers to encourage an adolescent's autonomy can lead to abrupt and destabilizing changes in the adolescent's care. It is useful at this point to underscore the particular challenges of adolescents in key populations. Adolescents and young people from key populations are at a significantly high risk of acquiring HIV. They are even more vulnerable than older cohorts to sexually transmitted infections and other sexual and reproductive health problems. Particularly for those under age 18, policy and legal barriers related to the age of consent prevent access to the range of services provided for key populations, such as testing and counseling and harm reduction. Adolescents from key populations face more stigma, discrimination, and violence than older people, and are subject to greater power imbalances in sexual relationships. It is therefore vital to consider skills-based, interactive, and participatory approaches to adolescent HIV services that are tailored to the needs of adolescents from key populations. Online and mobile health peer outreach approaches are particularly acceptable to adolescents in key populations. The community-based approaches to improve treatment adherence and retention that we have discussed are equally adaptable to the needs of adolescents in key populations. Peer support groups and safe spaces are especially effective channels for interventions to improve self-esteem and self-stigma in this vulnerable subgroup. Finally, wherever possible, the age-related barriers that prevent adolescents' access to comprehensive HIV services should be addressed through reconsideration of policies related to the age of consent. As we conclude, Let us consider recommendations on human papillomavirus infection and cervical cancer as they relate to adolescent girls living with HIV. Women and girls living with HIV are at an elevated risk for cervical cancer. Irrespective of age, therefore, cervical cancer screening is recommended in all women and girls as soon as they are diagnosed with HIV. WHO recommends the HPV vaccine for girls aged 9 to 13 years, including those living with HIV, who should receive the 3-dosing schedule. In conclusion, let us reflect upon the content shared in this module from your personal and professional perspectives. What are the WHO-defined characteristics of adolescent-friendly health services? Are there any differences between antiretroviral therapy for adolescents and adults? What is transition and why is it important? What are some of the specific needs of adolescents from key populations? Should girls living with HIV receive HPV vaccination? This concludes the training module on adolescent HIV care and treatment. Thank you for your participation. You may now exit the presentation.